interventional pulmonology, complex airway procedures, and also critical care medicine. He is awarded Best Pulmonologist in South India by prestigious magazines Outlook and India Today for the year 23-24 consecutively. Lokesh, stage is yours.
Thank you, sir. So at the outset, first I would like to welcome you all for the lung matrix. Thank you all for the overwhelming response. So before I start my topic, so I want to give a brief introduction about lung matrix. So we all know what is matrix. It is not movie matrix. As a doctor in biology, we have something called matrix, extracellular matrix, which connects both the cells all over the body. So in that way, we call it as lung matrix, where it connects multiple specialties related to the lung health, to promote the lung health and also to diagnose lung disease early. So that's the concept behind this. So and once again, I thank you all for coming over to lung matrix. So today my topic is on approach to non-resolving pneumonia, which is also very close to my heart. But my talk will be repetitive of many things today because it is already covered multiple topics from morning. It will be like we all see news channels, right? In 2 minutes they read about so many things, so many important news, then they'll finish in 2 minutes. So my talk would be similar to that. Excuse me if I have any repetitions. Thank you. So where is the pointer? Can I have? So if you call definition, there is no definition at all. So but most of the people believe that most of the pneumonias resolve in 4 weeks radiologically. But if it doesn't resolve after 4 weeks in a chest X-ray or CT scan, it is called as non-resolving pneumonia. So what are the factors? Do you think that after 4 weeks if we have something on X-ray, still it is there? Do you feel it is non-resolving pneumonia? No, because there are multiple factors which can affect the resolution on chest X-ray or CT scan. One of them is age, other one is comorbidities. The age more than 50 years, they take probably a little longer time than the people who are younger. Most of the people who are less than 50 years of age, they say that 90 to 100% resolve in 4 weeks. But in more than 50 years of age, only 20 to 30% of the people chest X-ray opacities resolve after infection. And also comorbidities. One is diabetes and also cardiac diseases and CLD, CKD, where they might be having immunocompromised status. It might take a little longer time than the normal people, young people. So we call these factors as slowly resolving pneumonia. And other two factors are severity, other one is infectious agent. When we know that it is severe ARDS, which has caused diffuse lung disease, obviously it is going to take 10 weeks or more than that to resolve. So there is no pointing in repeating in CT scan and X-rays when you know when it is going to take a lot of time to improve. And also infectious agent. For example, MDR, bugs, GNB, and also it might take a little longer time than streptococcal pneumonia and other mycoplasma, chlamydia species. So these are the factors which I have told you. These are the slow resolving pneumonia where the patient is showing clinical improvement, but X-ray CT scan is not showing any clinical improvement. So we don't treat X-rays, we only treat patients. So we don't need to worry about these set of patients. So next thing is, if I have to tell you causes of non-resolving pneumonia, I can tell you at least more than 100 causes, but I'm not going to discuss all of this. I'll only show you few important things which actually required. So one is misdiagnosis of pathogens. Second one is respiratory bacterial resistant bacterial pathogens, and host factors like immunity of the patient and development of complications from the initial pneumonia and post-obstructive pneumonia. It can be because of foreign body, it can be because of malignancy. And also non-infectious etiologies like neoplastic disorders, inflammatory disorders, drug-induced lung disease, pulmonary embolism, and congenital abnormalities like sequestration, they can present as non-resolving pneumonia. So I'll show you briefly a few cases, how it can present and how it can we face in real life. So this is a case I've seen in OPD. She's a around 50-year-old. She came to me with cough and fever. And the X-ray, you can see that there is some left upper lobe cavity and consolidation. So I asked for sputum because she is able to get sputum. I asked for sputum gene experts, sputum AB, sputum cultures. The sputum cultures have grown Klebsiella, and the gene expert was negative. So I started on an IV antibiotics. So I called. I have seen her after 2 weeks. Then the fever is still persisting, and also inflammatory markers were persistent. In between, it was a slight decline. Again, she had recurrent fever. After 2 weeks, again, the inflammatory markers were rising. So, in my mind, I have done sputum gene expert. I have done everything, but the patient is still having fever spikes. Why she is not improving? Then that was the state where I have done bronchoscopy and BAL. So, which is gene expert is positive. So, what, even though I have done the first step is correct, sometimes why it is negative? Probably sputum collection can be wrong, and also probably faulty test at the laboratory, because it was not done in my setup. So, I am not sure about that. So, where you feel that you feel of tuberculosis, but your results are not there, you always should do a proper sample, taking sample from the appropriate place from left upper lobe. Proper sample collection is important. That says from this case. The second case, this is also one of the recent case which I have seen. The patient is a diabetic, where you can see that left mid zone there is some consolidation kind of thing. So, if I have to name that sign, you know what I name that sign. This is the et al. Sign. So, this patient was treated with IV antibiotics. So, before coming to me over almost 2 weeks. Then the patient was not responding. The patient was having HbA1c of 14. The sugars were always, when he came to ER, he was having 450. So, this was the X-ray when he came to our place. Can you see that the progression within just 2 weeks of time, there was left upper lobe, both bilaterally diffuse cavitating lesions, most probably fungal pneumonia. That's what is in mind. So what can I do in these cases? Once you miss the bus, it's very difficult. If the patient comes to us at this state, probably we can do, this patient turned out to be mucormycosis. If you know at this state, we can at least start IV amphotericin B, and also you can do a lobectomy where you can save a patient. In this setup, in this condition, you're not going, whatever you do, most of the time, 95% we are going to lose the patient, even if you do IV amphotericin B, and you cannot do any surgery because that is already diffusely spread. So that is a message for only those patients with diabetes. We should be alert. If you see that kind of et al. Sign, you have to do proper sampling and act fast. They don't give much time. It's just 10 to 15 days. It is not months. So third case, this is another scenario where we come across regularly. This is a cavitation where you can see there the left upper lobe, and also multiple nodules. So this case, initial suspicion was tuberculosis or fungal pneumonia. So this turned out to be a nocardia. So what are the factors? What are the risk factors for nocardia? Any chronic lung disease like bronchiectasis or old tuberculosis, or any of these factors, COPD, all these factors, the risk of nocardia infection is more, and it is often missed. The lack of suspicion and also non-specific clinical radiological presentation, often mimicking like tuberculosis and fungal infections, we always miss this nocardia. If we ask for regular, like we ask for AAB, Gram-Shan and culture, we always write in the microbiology investigation. If you make sure that nocardia is also there in the investigation, first investigation itself, when you think of nocardia, because we always have risk factors are there, COPD, bronchiectasis, so you should also think of nocardia. You should write more frequently in your test. Definitely, if you alert your microbiologist, she will tell you that there is nocardia. There were a lot of cases in our center as well, which was diagnosed by nocardiosis. Another disease which is again presenting like cavitating pneumonia in the right lower lobe, and there is some consolidation in the left lower lobe. So this case turned out to be actinomyces. So again the same risk factor like I told before, chronic bronchiectasis, chronic bronchitis, COPD, all these old tuberculosis, these are more prone for actinomyces and diabetes as well. So the message I wanted to give from those infections is, most of the time when we treat tuberculosis and other infections, we should also think of atypical infections as well. So other thing is complications of initial pneumonia. This everybody knows. So left upper, most of the times when the pneumonia complicates, if the patient is not responding, the first step we have to do is at least ultrasound. If not the CT scan, we have to do ultrasound just to see if there is any quantity of fluid, and also to see the localization, if they have any localizations. If the patient has parapneumonic effusion, it is very unlikely the patient only responds to IV antibiotics, where you have to give either you have to do drainage with the needle, or else you have to do ICD. Sometimes if required, thoracoscopy to break the loculations. The earlier you do, you can save the lung. If you delay by 8 weeks, it is going to be restrictive lung disease by chronic empyema, leading to it might require decortication, the major surgery. So the earlier you identify, that is the best scenario. If the patient is not responding after 1 week, just do a ultrasound, simple ultrasound. If the patient is having effusion, easy to address. The second scenario is right upper lobe lung. You can see the lung abscess. And another common scenario, risk factors, again elderly, and also where they aspirate, it can lead to lung abscess, a common scenario. Unlike the pneumonia, they will take at least 8 to 10 weeks of IV antibiotics to respond. So, and also sometimes we have to be very aggressive. It might require drainage from like pigtail if it is acute. Sometimes it requires lobectomy along with IV antibiotics. So we have to be alert, because once you treat, it might lead to fibrosis, and also we may not go anywhere, especially in those patients who have on steroids or diabetics. It takes long time to recover. So then comes to inflammatory disorders. It is well covered by our colleagues, like systemic vasculitis, and also organizing pneumonia and cryptogenic organizing pneumonia, eosinophilic pneumonias, AIP, interstitial pneumonias, pulmonary alveolar proteinosis. These all look like infection. When the first presentation, if I have to tell you, the all presentation, when you think of when the patient comes to you in the first week or second week or third week, the first idea is we think of infection only, obviously. So just let me show you a few cases. I'll not take much of the time. So this is the case during the COVID time. So we were having a lot of mucormycosis during that time. This patient was seen ENT surgeon because of they were thinking of fungal sinusitis, but the patient was also breathless. So they have done the CT scan. This is the CT scan showing right upper lobe cavitating nodule and also left lingular consolidation. So initial thought process, because she is post-COVID, she also has COVID antibodies, we were thinking of fungal pneumonia. Then I have done a bronchoscopy. Here you can see, like madam was mentioning, the severe subglottic edema and also whole trachea bronchi is edematous. That's when, and also we have sent for BAL for all infections. So whenever you think of GPA or any vasculitis, you should always rule out infection in a country like India. So otherwise, without ruling out infection, you cannot give them steroid. So we have done that BAL and everything, it was negative. And also then we thought of she also has sinusitis and also cavitating nodules, she has subglottic stenosis, and we thought, are we missing anything? Then we have sent this markers, PR3 antibodies, which was very, very high. So she was diagnosed to have GPA, then we treated with rituximab. The story is, again, after starting rituximab, she developed tuberculosis. That is very common. So again, we had to give ATT. So it's very complex. Sometimes the disease becomes very complex, and the people die of infections. Like madam mentioned, the first cause to die of these inflammations are because of infections, secondary infections once you start. So the criteria madam already mentioned, I'm not going behind this. So other thing is organizing pneumonia. This is also very common we see. So when the patient comes to you with the pneumonia which is not responding to IV antibiotics, still having persistent fever spikes, persistent inflammatory markers, then that's when we think about, are we thinking of something else than infection? It looks like infection, but it is not infection. So what do we do about it? So if you, if the patient has any association like CTD, RA or SLA, we should first think about whether it is organizing pneumonia. Or else, because organizing pneumonia can be because of infections as well, and also because of drugs as well, then CTD, a lot of things. If you have to label that as cryptogenic organizing pneumonia, you have to rule out everything. That is also organizing pneumonia which responds well to the steroids. So here in this case, this is a RA, which was in a biopsy, it is showing intraalveolar buds of granulation tissue within alveolar ducts and alveoli. So do we really require to do a biopsy for every patient when you think of about it? No. At least if you can rule out infection, and also when you have strong suspicion of organizing pneumonia, so you can treat with steroids. At least when you have association with CTD, RA or anything of thing, you can treat with steroid. But if you want confirmation, yes, you have to do biopsy. This is a cryptogenic organizing pneumonia. Again, it is showing like a Gatol sign. If you to name it as cryptogenic, like I told you, you have to rule out at least so many causes, then only you can label it as cryptogenic organizing pneumonia. Then this is another scenario where the patient always slow insidious onset, cough, fever, not responding to antibiotics. You can see that peripheral predisposition of pneumonia and also septal thickening. It is eosinophilic pneumonia. When you're suspecting this, if you do a bronchoscopy, you will find more than 40% of eosinophilia. and also if peripheral blood eosinophilia more than 1000. So if you already start him on steroid, you might not see the findings, but if you directly do a bronchoscopy in a patient of eosinophilic pneumonia, you might see this, they respond with the steroids, and they might be have a recurrence as well. This is another scenario where this patient saw me probably 2 years back. This patient had a very young patient. He was treated for tuberculosis for 6 months. Spear negative tuberculosis for 6 months. The patient has not responded. So the patient was not responding. Again, he was put on 6 months of another 6 months of ATT. Total, before coming to me, he took 1 year of ATT because he was not responding. So there was empirical treatment. So if you look at this case, it was looking like there are a lot of treatment opacities and also some small nodules across the bronchivascular bundles. So if you have to typically, what is the name of the sign? Many of you can say this is a galaxy sign. So I was thinking probably it could be sarcoidosis. But in a country like India, before you say sarcoidosis, you have to rule out tuberculosis. So this is the case. The typical sign is a stage 1 sarcoid, where you can see 1, 2, 3 sign. What is the right paratracheal lymph node and bilateral hilar. This is a stage 1 where we may not require any treatment. But if you leave it, it might progress like this. But you have to observe these patients whether they are progressing or not. Some patients they progress, some patients they don't progress. But you have to tell the patient that you have to come for frequent observations. So it's very important. We usually see this in Western world. It is very common. We think sarcoid is so uncommon, but it is very common. If you not so, at least I can say it is not so uncommon. Another scenario where it is not infectious, where it is not inflammatory, where we can see in our daily practice. So these patients are also present with fever and dyspnea. When you do a CT scan, you might see a left upper lobe consolidation or GGO, which looks like infection. But you should have a strong suspicion of pulmonary thromboembolism in those patients who has risk factors like recent surgery and also immobility, bedridden patients, these patients, and also pregnant females. So where there is risk of or OLCP pills, so there is risk of PTE as well. These patients also present with fever and breathlessness. If you do a CT scan, only plain CT scan, you will not find anything except for GGOs, which can be reflection of infarct in the lungs. So if you do CTPA, then you will find out that these if you can't do CTPA, at least if you have suspicion, you can do a Doppler bilateral lower limbs. Next scenario, this is a common scenario again. This is a recent case, 80-year-old female. You can see the right lower lobe pneumonia, which is not resolving with IV antibiotic for at least 3 months. She is 80-year-old, you can see, and she was suffering with lot of like infections, recurrent admissions. Then found out in CT scan, they found out to have you can see a foreign body, opaque, and also causing right lower lobe consolidation, which is not responding to the antibiotics. So this is there was a bronchoscopy done by one of our colleagues. They have seen this foreign body inside the right lower lobe. They tried to do it, but it didn't come out. So they referred to us. She is 80-year-old. So how much to do for 80-year-old? So that is a question in the back of mind. So whether she can tolerate the procedure for a rigid bronchoscopy. So all these questions are there. But if you don't do a bronchoscopy, she will live with that. She will come back to you again and again. She will admit every month. So that is the scenario. So you have to explain the risk. You have to do a bronchoscopy. Then we did the bronchoscopy under general anesthesia. Then it turned out to be. It looked like stone. I don't know what it is, whether it carries teeth. I was discussing with my colleague, Dr. Vikram, as well. So he also told that, so can it be a broncolith? I said, oh yes, it can be a broncolith, but we didn't send it to biochemistry to see whether broncolith or not. But this patient recovered well. Then she came to follow-up as well. She's very happy. And you don't need to do anything. You don't need to give steroid also. There was a lot of inflammation in the right lower lobe. There is a lot of granulation to reach that stone. Or foreign body. So after if you just remove it, they will just respond. That's it. You don't need to do anything. And there was stenosis also. I'm very sorry. So there was so many drugs which we commonly use. The nitrofurantoin, which for UTI regularly, many patients use it for prophylaxis as well. Methotrexate, which we use it for CTD, and also amiodarone for cardiology patients. All these and also our anti-neoplastic drugs. Most of these drugs can lead to drug-induced lung disease. So you have to be very careful, especially these common drugs. At least we can think of when the patient you feel that is non-infectious, it can cause non-resolving pneumonia as well. They respond well with the steroids. Other thing is neoplastic disorders, where you can see here the right lung is having endobronchial growth, leading to collapse of the right lung and also probably recurrent infections. Here also you can see the carcinoid, which is left endobronchial obstruction is there. So patient will have obviously non-resolving pneumonia. So I'll end with just two cases, just to see in 5 minutes I'll end with this. So she is a 50-year-old female with symptoms of cough and chest pain for a month. So she was evaluated with outside chest radiograph. CT chest has shown, CT chest has shown the left upper lobe consolidations, looking like pneumonia. She was treated with IV antibiotics, not responded. Then she also underwent CCT chest. And in contrast CT, there was no enhancement of the consolidations. And also she underwent PET scan just to see if any malignancy. There was only this consolidation which is not picking up on FDG as well. So it is, though no FDG pickup, there is no contrast. So this patient was referred to me just to see if any fungal pneumonia or any other rare infection or anything else. So this patient, we did bronchoscopy and transbronchial lung biopsy from the left upper lobe nodule. You can see this beautiful picture given by my pathologist. It is a lipidic pattern adenocarcinoma. So this is also not so uncommon. So adenocarcinoma, which previously called as bronchiolar carcinoma, now it is labeled as lipidic pattern adenocarcinoma. So this also presents like pneumonia. So you should be very careful. At least in last 4 years, I've seen at least 5 cases. So this is not so uncommon. If one practitioner can see 5 cases, you can imagine what is the load of these kind of people in the society. So this is another close to my heart. Again, this patient, 20-year-old female, sometimes rare diseases can also present like non-resolving pneumonia. That's why I just want to show this. So she is a 20-year-old female with history of cough and mild hemoptysis for 10 days. On evaluation, she has iron deficiency anemia, hemoglobin of 10.1 gram per dl. CT chest suggests for diffuse ground glass opacities. She is normotensive, maintaining saturation of 90% room air, and she drops to 70% when she walks at least 5 minutes. So she had history of anemia since the age of 14 years, for which she received blood transfusions at multiple times and also iron injections multiple times. So she was also treated for pulmonary tuberculosis because she was having recurrent pneumonia and hemoptysis. She took ATT for 18 months. Can you imagine that? Without any sputum test and also gene expert. So based on hemoptysis and infiltrates. So these are CT scan showing multiple ground glass opacities diffusely spread across the lungs. So she also had the miscarriage just after 1 year after her marriage. So she had waxing and waning symptoms of recurrent pneumonia. Then based on above findings, family was counseled for bronchoscopy, lavage, and also transbronchial lung biopsy. So, and also we have to explain the risk. She can't even walk for 5 minutes, and you have to do a bronchoscopy and biopsy on a patient who is desaturating. So what is the risk of doing a biopsy in these patients? We can push them onto ventilator. So always that risk is there. So you have to tell your patient so that the risk of going on to ventilator. Then you have to explain everything because they come walking, but they can't accept after procedure if something happens to the patient. So you have to be very vigilant in this patient. This patient we did transbronchial lung biopsy. Luckily, she didn't deteriorate. She happily only on oxygen for 1 or 2 days. Then we discharged her. So what happened during that? So can you see this beautiful picture? H&E stain showing ulnar macrophages flooded with hemosiderin. And also this is Pearl stain. This is all blue color. What you're seeing here is hemosiderin-laden macrophages suggestive of hemosiderosis. That means there is something bleeding pulmonary hemorrhage is happening in the lung. So, but causes in young female, there can be multiple again. So you need to rule out all those causes. So in a view of DH in young female, the secondary causes are worked out with ANA profile, APLA, vasculitis workup, PR3 MPV antibodies, and everything was negative. And rheumatologist opinion was sought. She was opined patient doesn't have any CTD features suggestive of autoimmune cause. So again, to label it as idiopathic pulmonary hemosiderosis, we need to have celiac disease workup also. Sometimes these patients also have celiac disease association. So after ruling out everything, the final diagnosis came as idiopathic pulmonary hemosiderosis. The story ended after 8 years of suffering. So she was put on steroids. She is responding well, and for us it feels good when you find a rare diagnosis, but not for the patient. She's still having symptoms, and after starting steroids, she developed nocardia. Can you imagine? She developed nocardia, and we treated. She responded well. She went back home. She's doing well now. She's still coming to follow up. So I want to give this message saying that radiologically appearing cavity or consolidation is not always infection. think about alternative etiology if the patient is not improving, and always collaborate with the colleagues in the best interest of your patient health. Thank you very much. Questions we can take it.